the smell of hospital hand sanitizer.
Oh, yeah.
It is that sharp, that highly chemical, sterile alcohol scent. It just immediately hits the back of your throat the absolute second those heavy automatic sliding doors pull open.
It is entirely unmistakable, and it triggers an instant physical reaction.
Right. It really does.
Yeah.
And then there's the sound. It's the relentless rhythmic beeping of a pulse oximeter echoing down a hallway. And that sound, whether you want it to or not, it just instantly becomes a metronome for your own anxiety.
Absolutely. It gets right into your nervous system.
It does. And then you have the harsh, unforgiving glare of those fluorescent lights. They're reflecting off these perfectly buffed linoleum floors at 3 in the morning. The rest of the world is completely asleep, but you are wide awake, sitting in a vinyl chair, watching a monitor.
Just staring at the number.
Exactly. Staring at the numbers. And if you are listening to this right now, you know exactly what I'm talking about. So welcome to the Deep Dive. Today, we are undertaking a very focused, highly specialized exploration.
We really are. We have a massive stack of sources today.
We do. And we are directing this entire conversation specifically to our listeners tuning in from the PURA Syndrome Podcast. We are talking directly to you. You are the parent, the carer, the fierce, exhausted, unyielding advocate of a child who has been diagnosed with PURA syndrome.
And we see you. We know how incredibly hard you are working.
Yeah, we do. Our topic today is hospital survival kits. Specifically, we are talking about being prepared for the unexpected because whether you are meticulously prepping for a planned week-long admission for an intensive EEG, or you are, still recovering from a frantic, terrifying midnight run to A&E for respiratory distress, we fundamentally know one thing.
And what is that?
The hospital environment is just deeply, deeply overwhelming.
It is entirely overwhelming. And I think one of the most difficult realities we have to acknowledge right at the top of this deep dive is a very specific myth. It's the myth that repetition breeds ease.
Oh, wow.
Yeah.
Like the idea that because you've done it before, it should be a breeze now.
Exactly. A hospital stay does not necessarily get easier simply because you have navigated it a dozen times before. It just doesn't.
Right. Because the environment itself is so hostile to comfort.
Precisely. The hospital is an ecosystem designed entirely around clinical efficiency. It is not designed around human comfort. I mean, the sensory environment alone is intense. The unpredictable alarms, the constant interruptions, the extreme temperature fluctuations, that is enough to put any perfectly healthy adult completely on edge.
Oh, for sure. It's a sensory nightmare.
Right. Now take that baseline of stress and multiply it by the complexities of a family dealing with a severe, highly specific medical crisis involving a rare neurodevelopmental condition like PURA.
The friction there must be immense.
It is immense. The friction between what your child fundamentally needs to feel safe and regulated and the hospital's rigid operational machinery, it is just huge.
Which is exactly why we pulled together such a diverse, comprehensive stack of materials for this deep dive today. I mean, we really dug deep.
We had to get the full picture.
Right. So we are looking at peer-reviewed medical literature that details the very specific clinical phenomenology of PURA syndrome. We're analyzing these fascinating recent studies on the implementation of sensory toolkits in emergency departments.
Those studies are incredible, by the way.
They really are. We'll get into those. And we have meticulously combed through hospital planning packets from some of the top pediatric institutions in the world. Places like Boston Children's Hospital and Lurie Children's.
The gold standard institution.
Exactly. We've also pulled in the dry but totally necessary administrative guidelines regarding financial benefits for carers. But honestly, the most crucial sources in our stack today, they aren't the academic papers.
No, not at all.
They are the raw, unfiltered, real-life survival guides, the blogs, and these amazing YouTube transcripts created by other parents of medically complex children.
Yes, the veteran parents.
Right. These are the people who have been in the trenches. They are the ones who know the actual reality on the ground.
And looking at all of these sources together, our mission today becomes very, very clear. We are going to build the ultimate, highly specialized go bag and hospital survival kit.
I love that. The ultimate go bag.
But we must be completely clear from the outset here. We are actually talking about two distinct kits. One kit for your child and one kit for you.
Right, because you can't just pack for the patient.
Exactly. Because what emerges When you synthesize the official medical protocols with the lived experiences of these veteran parents is a profound, entirely necessary shift in mindset.
A mindset shift. Let's talk about that.
Well, packing for the hospital is not just this boring logistical exercise of making sure you have clean underwear and a spare toothbrush. Packing is an act of empowerment. It is a tangible, physical way of declaring your role in that hospital room.
Okay, let's unpack this.
Okay.
Because if packing is empowerment, what exactly are we empowering ourselves to do? Like, what is the end goal here?
You are empowering yourself to transform your role. Think about it. The hospital system, just by its very nature, it can make a parent feel like a passive, overwhelmed bystander.
Yeah. You're just sitting in the corner in that terrible vinyl chair while 5 clinical professionals surround your child's bed.
Exactly. But you cannot be a bystander. You are the resident expert of your child's care. Absolutely no attending physician, I don't care how brilliant they are, knows your child's baseline better than you do.
That is such a powerful way to frame it. The resident expert.
Right. So the items you carefully curate and pack into these bags, they are not just supplies. They are literally the tools of your trade as that resident expert.
Okay, I am so ready for this.
Yeah.
Because when we normally talk about packing a bag, the immediate human instinct is to grab, pajamas and a phone charger.
Sure. The basics.
Right. But according to the materials from Boston Children's and Lurie Children's, the absolute first thing we need to put in this go bag actually has no physical weight at all.
It doesn't weigh a single ounce.
No. It is information. We need to build what we're calling the informational go bag. And the absolute cornerstone of this is something they refer to as a medical passport, or sometimes an all-about-me sheet.
Which is absolutely essential.
It really is. And thinking about the reality of an A&E admission, this just makes complete sense. I mean, in the intense brain fog of a medical emergency, when the monitors are going off and like 3 different nurses are asking you rapid-fire questions simultaneously.
It's chaos.
It is chaos. Relying on your panic memory to deliver a perfectly condensed, accurate medical history is a terrible strategy. Having a pre-written, highly structured summary is just vital.
It is arguably the single most vital tool you possess. And to really understand why, we have to look at the epidemiological data surrounding PURA syndrome.
Let's do it. What are the numbers?
We are talking about a condition that is exceptionally rare. Current medical data suggests there are roughly 750 to 800 identified cases in the entire world.
Wow. Only 800 worldwide.
Exactly. So the statistical probability is that when you rush through the automatic doors of your local emergency department, the attending doctors, the triage nurses, the specialists on call, they will not know what PURA syndrome is.
They've probably never even heard the acronym.
Right. They may have never encountered a single case in their entire medical careers, let alone studied it in depth during their medical school training.
So you really can't assume they will just politely pause the emergency, pull up a medical journal database, and read up on it while your child is actively struggling to breathe.
No. You are walking into a room with highly trained medical professionals, but regarding this very specific condition, you have to instantly become the educator.
That is a massive responsibility for a parent who is already terrified.
It is. And that is why your medical passport needs to quickly, cleanly, and authoritatively explain the core clinical phenomenology to a physician who is essentially just scanning the document while actively trying to stabilize a patient.
Right. It needs to be readable in 10 seconds.
Exactly. Now, clinically speaking, PURA syndrome is caused by a heterozygous pathogenic sequence variant in the PURA gene, which is located on chromosome 5q31.
Okay, let's pause right there. That is a very dense piece of genetics. Let's break down exactly what that means and, more importantly, why it matters to the clinical picture the parent is trying to paint for the ER doctor.
Certainly. So the PURA gene provides the instructions for making a specific protein called pure alpha.
Okay. Pure alpha.
Right. And this protein is essentially a master regulator. It is absolutely crucial for normal brain development and the proper functioning of the entire nervous system. Now, that word heterozygous.
Yeah, what does that mean in practical terms?
It means the child has one working copy of the gene and one altered copy. Because that one altered copy is enough to disrupt the production or the function of this master regulator protein, the child's entire neurodevelopmental trajectory is shifted.
Wow. One altered copy changes everything.
It does. That is the biological root of the condition. But practically speaking, for the emergency room doctor who needs to keep your child safe in the next 5 minutes, your passport needs to translate that genetic root into immediate physical realities. You need to explain the classic triad of symptoms.
Right. The literature points to a very specific triad, especially when we were talking about neonatal presentation or ongoing chronic management. So first, there's severe hypotonia.
Yes.
Second, respiratory insufficiency. And third, significant feeding difficulties, specifically dysphagia.
Exactly. And we need to ensure we understand the underlying mechanisms behind those medical terms so they can be effectively communicated by the parent. Let's look at hypotonia first, which the older medical literature sometimes unfortunately refers to as the floppy baby phenotype.
Floppy baby. Such a tough term to hear.
It is, but hypotonia is not synonymous with muscle weakness, even though they often present together.
Oh, wait. Hypotonia and weakness are different.
They are very different. Weakness is a lack of strength, but hypotonia is a lack of resting muscle tone.
Okay, explain resting tone.
Sure. Even when a healthy muscle is completely relaxed, it maintains a slight continuous contraction. It's this background tension that keeps our posture stable and our joints aligned, like a car engine idling.
Oh, okay. The car is in park, but the engine is still running a little bit.
Exactly. In PURA syndrome, because of that disrupted PUR alpha protein in the brain, the central nervous system fails to send those continuous baseline idling signals to the muscles. The result is a profound lack of resistance to passive movement.
So the ER doctor needs to know this because it drastically impacts how the child must be physically handled.
Precisely. It changes how they must be positioned to keep their airways open and how they must be supported during simple procedures like starting an IV.
That distinction between weakness and resting tone is massive, and it directly connects to the second and third parts of that triad, right?
It does. If the brain isn't sending the right signals to maintain resting muscle tension in the arms and legs, it's also struggling to send the complex, highly coordinated signals required for swallowing. That is the dysphagia.
And most critically, in an emergency setting, the respiratory insufficiency. We are talking about central sleep apnea here.
Yes. Central sleep apnea is where the brain simply forgets to tell the lungs to take a breath. It leads to long, dangerous pauses in respiration.
So the mechanical hardware of the lungs might be perfectly fine.
Exactly. The lungs themselves are healthy, but the neurological software driving them is glitching.
Wow. So when you, the parent, hand a physician a concise, well-organized medical binder that clearly articulates this triad hypotonia, central apnea, dysphagia, and details exactly how these manifest in your specific child, you are doing something really remarkable.
You are. You are executing a profound power dynamic shift in that room.
You really are. You aren't just an anxious, panicked parent crying in the corner. You are establishing yourself as a peer. You are an active collaborator in the care team.
You are speaking their professional language, and you are providing the exact clinical data they urgently require to make safe treatment decisions.
But wait, thinking about the modern hospital system, isn't this exact clinical data already supposed to be at their fingertips? We have these massive electronic medical record systems now, the EMRs.
We do.
So if we were rushing to our usual regional hospital, why do I need a paper passport at all? Shouldn't the doctor just look at their computer screen, see the PURA diagnosis, and instantly know the history?
It is a totally logical assumption, but it fundamentally misunderstands how electronic medical records actually function in the middle of a crisis.
Okay, how do they function?
Well, think of a child with complex medical needs who has been in the hospital system for, say, 5 years. They have detailed notes from neurology, pulmonology, gastroenterology, orthopedics, physical therapy, the dietary team.
It's essentially a giant, messy filing cabinet.
Exactly. Technically, yes, the entire history of their oxygen desaturations or their past adverse reactions to a specific anesthesia is in there somewhere.
But the doctor has to dig for it.
That is an excellent way to conceptualize it. The EMR is a filing cabinet stuffed with thousands of pages of deeply complex specialist notes. And in an acute emergency, time is the single resource the medical team absolutely does not have.
Right. They can't spend an hour reading.
The attending physician cannot spend 45 minutes reading 5 years of neurology updates before administering a critical anti-epileptic drug.
That makes total sense. So your paper all about me sheet, your medical passport, it acts as the brightly colored neon sticky note slapped right on the front of that massive filing cabinet.
Yes, a sticky note that says, "Read this first to keep this patient alive today."
I love that visual. And the most critical piece of data on that neon sticky note, according to the veteran parent, it's your child's specific baselines.
Baselines seem to be the recurring, non-negotiable theme in all the parent survival guides we looked at.
Right, because what constitutes a quote-unquote normal vital sign for a typical pediatric patient might actually be an active red flag for a child with PRA.
Exactly. Let's look at temperature regulation, for example. Many children with PURA syndrome experience chronic hypothermia. This is due to autonomic dysregulation.
Okay, autonomic dysregulation. Let's break that down for a second. The autonomic nervous system is basically the body's autopilot, right?
That's a great way to put it, yes.
It controls the things we don't actively think about: heart rate, digestion, and our internal thermostat.
Correct. And in PURA syndrome, that autopilot is often malfunctioning. So the internal thermostat doesn't hold the body temperature at the standard human baseline. Their normal baseline body temperature might run significantly lower than average.
Wow. Okay, so imagine you are in triage at the ER.
Right.
The triage nurse uses a thermometer on your child, and it reads 98.6 degrees Fahrenheit, or 37 degrees Celsius.
For 99% of the patients that nurse sees, she notes that as a perfectly normal, healthy temperature. No fever at all.
But if your child's established baseline is actually 1.5 degrees lower than that normally,
Then a reading of 98.6 means they are, in fact, running a significant dangerous fever.
Oh my goodness.
yes. If you haven't documented and forcefully communicated that altered baseline to the staff, the medical team will completely miss the early warning sign of a severe infection.
Because the system's default logic completely fails them.
Entirely. You have to override their system with your data. And you also need to document their baseline heart rates, their baseline oxygen saturations, and crucially, exactly how your child communicates pain or distress if they happen to be nonverbal.
Right. And beyond just the physiological baselines, your informational go bag must contain a highly specific inventory of their hardware. The Leary Children's Guide is incredibly adamant about this point.
Hardware is huge. You must know the exact specifications, the brands, and the precise sizes of every single piece of medical equipment your child relies upon.
Oh.
You cannot walk into a hospital and just vaguely say, they have a feeding tube.
Because there isn't just one type of feeding tube.
Far from it. You
Yeah.
need to be able to state definitively they have a 14 French, 1.5 centimeter low-profile balloon gastrostomy button made by specific brand.
It has to be that specific.
Yes. You need the exact specifications for their CPAP machines, the exact settings programmed into their vagal nerve stimulators, the precise diameter of their tracheostomy tubes.
But why is the exact brand and millimeter measurement so critical in the heat of the moment? Like, can't the hospital just swap it for whatever similar brand they have in their stockroom?
Often, no, they cannot. Imagine it is 3:0 a.m. Your child's gastrostomy button gets snagged on a blanket and is completely dislodged.
Oh, nightmare scenario.
Right, and the stoma, the hole in the abdomen, it can begin to close incredibly quickly. The on-call resident needs to replace that button immediately. Now, if you know the exact size and brand, they can send a runner to the specific supply closet that holds that specific item.
And if you don't know it?
If you don't know it, they have to guess. Or try to measure the stoma while the child is distressed. Or worse, the hospital might not even stock that exact low-profile button.
So what do they do then?
They have to insert a temporary, much less comfortable long tube just to keep the tract from closing up. Knowing your specs prevents delays in care and totally unnecessary physical trauma to your child.
Which flows perfectly into the next critical part of the informational go bag, the medication inventory. Every single parent advocate in these survival guides hammers this point home relentlessly.
It is a non-negotiable rule.
Yes, you need a beautifully tight list of all medications. That includes the exact milligram dosages, the delivery methods, and the administration times. But the real rule is that you must put the actual physical medications with you in the bag.
This is a systemic vulnerability that catches almost every single medical parent completely off guard the first time they experience it.
Because we tend to view major pediatric hospitals as these bastions of infinite medical resources.
We do. We assume their pharmacies look like massive Amazon warehouses containing literally every drug known to science.
Right. But they don't.
They do not. Hospital pharmacies operate on highly optimized, very strict inventory management systems. They only stock what is most commonly needed by their specific, everyday patient demographic.
So if your child is on a highly specialized name brand anti-epileptic drug that is rarely prescribed,
Or if they require a very specific pre-mixed ketogenic formula to maintain metabolic seizure control, The hospital pharmacy likely does not have it sitting on the shelf.
So what actually happens in that scenario?
Yeah.
The doctor writes the order for the rare med, the pharmacy receives it, and then what?
Then the pharmacy has to order it from an outside specialized supplier or maybe a regional distribution hub. And that logistical chain can easily take 24 to 48 hours to complete.
Oh, wow. 24 to 48 hours. And a neurological condition like severe epilepsy does not care about supply chain logistics.
Not at all.
You cannot negotiate with the seizure threshold. If your child misses a single dose at 8:20 p.m. because the pharmacy is waiting on a delivery truck, you could trigger massive breakthrough seizures.
And that can result in a massive backslide in their entire neurological baseline. You absolutely cannot afford that delay.
Not ever.
This is exactly where you, as the parent, act as the final critical safety check against systemic bottlenecks and preventable medical errors. By bringing your own physical supply of their specialized medications and formulas from home, you ensure that your child's therapeutic blood levels remain stable while the hospital bureaucracy takes the time it needs to catch up.
That is just brilliant. And that perfectly bridges us from the paperwork to the physical reality of the ward. Because paperwork, no matter how brilliantly it's organized, cannot magically materialize delayed medication.
No, it cannot.
That physical reality is why parents rely so heavily on the second major component of our preparation, the child's physical go bag. And right at the top of this list is a concept the community calls the 24-hour emergency stash.
This is a brilliant, totally battle-tested strategy drawn directly from the lived experiences of parents. It's notably highlighted in the Parent XP YouTube transcript and heavily reinforced by the hand-to-hold hospital packing guides.
I loved the Parent XP video.
It's so informative. The core concept here is creating a totally self-contained ecosystem within your go bag. You pack absolutely everything your child needs to survive and maintain their specific routine for one full day, completely independently of the hospital's resources.
Watching that Parent XP video is an incredible exercise in perspective. The mother is talking to the camera while actively packing her daughter's bag, and you get this raw, unfiltered glimpse into the immense cognitive load of medical parenting.
The mental math is exhausting.
It is. She isn't just throwing in a few extra cute shirts. She is counting out exact numbers of syringes for administering daily meds. She is packing specific pre-blended tube-feeding meals. She is packing specialty pads, wipes, and nappy disposal bags.
And she makes a really profound observation while doing it.
She does. While she's packing these nappies, these diapers, she stops and makes this incredibly poignant observation. She's looking at the physical size of the nappies, and she wonders aloud at what point they're going to get so large that standard disposal bags simply won't work anymore, and she will have to start packing actual full-size bin bags.
Let's just sit with that reality for a moment, because it really highlights the chronic, ever-evolving nature of complex caregiving.
Yeah.
The general public, they view a hospital bag as something you pack for a discrete one-time event. Having a baby, getting your appendix removed, you pack it, you use it, you unpack it.
Right. It's temporary.
But for a parent of a child with PURA syndrome, the hospital bag is a permanent fixture in the hallway, and its contents continually morph to reflect the physical reality of a child who is growing older, growing larger, yet remaining fundamentally medically dependent. It is literally a visual timeline of chronic illness.
It really is. It's a stark reminder that the logistics never stop. They just change scale as the child grows. Now, returning to the clinical rationale for this 24-hour stash, it isn't just the pharmacy that runs slowly, right? The dietary department is its own massive bureaucracy.
Indeed it is. Hospital kitchens are massive logistical operations trying to safely feed hundreds of patients, all with vastly different dietary requirements.
So what happens when you get admitted?
When your child is admitted, the attending physician must first write a dietary order. Then, that order must be reviewed and approved by a clinical dietitian to ensure it meets nutritional and safety guidelines. Only then is it finally sent to the kitchen.
That already sounds like a multi-hour process.
It is. Now, if your child requires a highly specific blenderized G-tube diet, perhaps dealing with specific allergies or required consistencies for a very sensitive digestive tract, the kitchen may need to specially source those ingredients. Then they prepare them in a sterile environment and then schedule the delivery to your specific ward. That entire chain of approval and preparation can easily consume 12 to 24 hours. Having your 24-hour stash of pre-blended meals and feeding pump bags guarantees your child doesn't miss critical nutrition while you are just waiting for a dietitian to sign a form on another floor.
It's all about building a bridge over that chaotic gap. Between the moment you walk through the emergency doors and the moment the hospital system finally wraps its arms around your child's highly specific needs.
That is exactly what it is, a bridge.
And part of navigating that physical reality involves strategic wardrobe choices.
Mm-hmm.
Normally, if you are packing a bag for a weekend trip, you are thinking about aesthetics, what looks good.
Right.
But when you are packing a hospital go bag for a medically complex child, fashion is completely irrelevant. You're packing strictly for access.
Access and damage mitigation. The sources are incredibly specific about how to dress a child for a hospital stay, particularly because children with PURA syndrome frequently battle severe epilepsy and neurological complications.
So they are going to need specific tests.
Yes. A hospital stay will very likely involve neurological testing. They will be admitted to an epilepsy monitoring unit, an EMU, or they may have to undergo a stereo EEG.
Let's explain what an EMU stay actually entails, because it dictates this entire wardrobe strategy. In the Parent XP video, the mom specifically points out that she is packing pajamas that are notably too big for her daughter, and crucially, they all open completely down the front with snaps or zippers. She explicitly says she throws out all standard t-shirts. Why?
Because of the complex physical mechanics of an EEG. To monitor the brain's electrical activity, a specialized technician must apply a matrix of electrodes across the child's entire scalp.
And they don't just stick them on with regular tape.
No, these aren't just taped on. They are secured using a really strong specialized medical paste or a collodion glue. And then the head is often wrapped tightly in gauze to keep everything perfectly in place. Dozens of wires trail from the child's head to a monitoring machine next to the bed.
So that you're literally tethered to the machine.
Yes. Once a child is completely wired up into this matrix, pulling a standard tight-fitting t-shirt over their head is physically impossible.
Because if you try to pull a shirt over that massive EEG wrap, you are going to snag a wire.
Precisely. And snagging a wire can pull the electrode clean off the scalp. Not only is that painful for the child, but it completely ruins the integrity of the data being recorded.
Which is the whole point of being there.
Exactly. If the data is compromised, the test fails, and the entire grueling, stressful process has to be repeated. By utilizing adaptive clothing like oversized tops that button down the front, or specialized adaptive shirts with snaps along the shoulders and arms, you allow the medical team full access.
The nurses can check IV lines, apply stethoscopes to the chest, and the parent can change the child's clothes without ever disturbing the critical wiring on their head.
It is a game changer for reducing stress on the ward.
Now, there was another seemingly bizarre detail in that packing video that I really wanted to ask you about. Right before they leave for the hospital, the mother talks about sitting down and meticulously French braiding her daughter's hair into two very tight braids.
Yes.
On the surface, worrying about a neat hairstyle right before a traumatic hospital admission seems totally contradictory. What is the hidden logic there?
The hidden logic is trauma prevention, and it's born entirely out of harsh veteran parent experience. We just discussed that collodion glue and thick paste used to secure the EEG electrodes, right?
Right. Highly sticky stuff.
Now, combine that incredibly sticky substance with prolonged bed rest. A child in an EMU is often confined to the bed for days at a time. They're constantly rolling their head back and forth on a cotton pillow as they sleep or as they watch a tablet.
Oh, I see where this is going.
If the child has loose hair, that constant friction, combined with the medical glue, will rapidly twist their hair into a severe, impenetrable, matted bird's nest.
Oh, the removal process for that must be an absolute nightmare.
It is agonizing. You are dealing with a child who is already exhausted, potentially post-ictal after having a seizure, and profoundly sensory overloaded. To then subject them to an hour of painful pulling and tearing just to get the glue out of their hair, it is deeply traumatizing.
So the braids prevent that.
Yes. By tightly French braiding the hair away from the planned electrode sites before you even step foot in the hospital, you isolate the hair. You prevent that severe matting from occurring in the first place.
That is brilliant. And to connect that brilliant preventative measure to another great hack from the survival guides, packing baby oil.
Yes. The baby oil hack. This is a classic. The medical staff have specific chemical solvents to remove the collodion glue, but those solvents can have a harsh, terrible smell, like pure acetone, and they can really irritate the skin.
Which a child with sensory issues is going to hate.
Exactly. Veteran parents swear by standard, gentle baby oil and a soft foaming sponge. Applying baby oil to the glued areas and just letting it sit breaks down the adhesive naturally and gently. It allows the electrodes to literally slide out of the hair without pulling, without chemical smells, and without tears.
It is exactly that kind of highly specific granular knowledge that transforms a hospital stay from a nightmare into something survivable, which provides the perfect transition into our third major category.
Yes, the sensory toolkit.
Right. We've managed their physical comfort. Now we must manage their neurological comfort. We need to build the sensory and communication toolkit because, as we've alluded to, the baseline state of a hospital is sensory assault.
It is the absolute antithesis of a calming, regulated environment. To understand how to combat this, we can look at a fascinating piece of research from the journal Pediatrics and Child Health.
Let's dive into that study.
The researchers conducted a study on the implementation of specialized sensory toolkits in emergency departments, specifically targeting children with neurodevelopmental conditions like autism spectrum disorder. And while the clinical focus of the study was ASD, the neurological principles and the practical applications are directly, critically relevant to patients with PURA syndrome.
Let's break down why that is. The medical literature highlights that children with PURA syndrome often present with profound intellectual disabilities and can have intense, very complex sensory profiles.
Yes, they might be incredibly hypersensitive to certain stimuli.
Now, imagine putting that highly sensitive neurological profile into an emergency department. They are subjected to harsh, unyielding fluorescent lights. The temperature fluctuates wildly. But most distressing of all is the unpredictable tactile input.
Constant touching.
Right. They are constantly being touched, prodded, and sometimes restrained by adult strangers wearing scary masks and gloves.
And we must view this through the lens of a child who likely cannot verbally articulate their terror or their physical discomfort. Think about it. When a neurotypical adult is cold, they just say, "Excuse me, can I have a blanket?"
Simple.
But when a child with severe neurodevelopmental delays is cold, terrified, and blinded by lights, that intense sensory overload has nowhere to go but out. It manifests as severe, sometimes violent agitation.
It's their only way of communicating distress.
Exactly. As the literature notes, the profound frustration caused by the intersection of communication barriers and sensory assault can even lead to acute self-injurious behavior. The environment literally causes them to hurt themselves.
That is heartbreaking.
It is. The Pediatrics and Child Health study sought to mitigate this. They surveyed parents before implementing the toolkits, and 80% believed having sensory tools would improve the catastrophic ED experience. After the toolkits were rolled out, 100% of the parents who utilized them reported that they were helpful.
The success rate is undeniable. 100% is huge in clinical studies. But for me, the truly fascinating part of that study wasn't the quantitative data proving the kits worked. It was the qualitative feedback on how parents reacted to the specific items inside the kits.
It was so revealing.
The hospital tried to standardize it, right? They created a uniform kit containing a light wand, a squeeze ball, a push-pop bubble toy, and a few other standard sensory items. And the feedback they received was wildly, almost comically contradictory.
It was a perfect illustration of neurodiversity in action. The researchers received feedback from one parent explicitly requesting that they add more items specifically designed for chewing.
So more chewables.
But then, the very next piece of feedback they received from a different parent demanded the complete elimination of all chewable items from the kits. One parent praised the battery-operated light-up toy as a total lifesaver. Another parent submitted a complaint suggesting the light-up toy be removed immediately because the flashing lights triggered massive overstimulation in their child.
The hospital was trying to build a one-size-fits-all solution for a population where one size literally fits no one.
Exactly. It's impossible to standardize.
So the takeaway for our listeners is simple. Do not rely on the hospital's child life specialist to magically produce the perfect sensory kit for your child. They simply can't. You have to pack a highly individualized toolkit. You have to know your child's specific neurological profile.
You are the expert on what regulates them.
Right. What acts as a calming, grounding anchor for one child might be a massive dysregulating trigger for another.
Let's look at the chewables, for example. We know that children with PURA syndrome often face complex feeding difficulties, as we discussed with the dysphagia. Consequently, their relationship with oral motor input is incredibly complex.
So how do you pack for that?
Well, if your child is a sensory seeker who regulates their nervous system through intense oral input, packing high-quality, durable chew tubes is non-negotiable. Without that specific outlet, they may resort to chewing on their own hands, their clothes, or dangerously on IV tubing.
Oh, wow. Yeah, you do not want them chewing an IV line.
Exactly. Conversely, if your child requires deep, proprioceptive pressure to calm their central nervous system, you must bring their specific weighted blanket or weighted lap pad from home. The hospital's thin cotton sheets provide zero proprioceptive feedback.
And crucially, the Boston Children's Hospital Planning Packet gives parents explicit permission to use these tools. Under their accommodations section, they clearly state that children have a fundamental right to access sensory items and toys during their care.
That is such an important validation.
It is. You do not have to apologize for using them. Right. You can advocate forcefully. You can put a sign on the door or look the triage nurse in the eye and say, I know you need to take their blood pressure, but my child requires 2 minutes with their weighted blanket and their noise-canceling headphones before you touch their arm. We're going to do that first.
That is exemplary advocacy. It sets the boundary. And that perfectly segues into the second half of this toolkit. Managing the incoming sensory environment is only half the battle. The other half is managing the outgoing communication.
Bridging the communication gap.
Yes. We have to talk about bridging that gap. As we established, the vast majority of children with PURA syndrome are nonverbal or possess minimal, highly restricted spoken language. Think about the profound vulnerability of that state.
It's terrifying to imagine.
If they are experiencing acute shooting pain in their abdomen, they cannot press the red nurse call button, wait for the intercom, and politely say, "Excuse me, my stomach hurts terribly."
They are completely reliant on others to interpret their distress, which means you, the parent, have to physically pack their voice and bring it with you to the hospital.
It is the most critical piece of equipment in your bag. If your child utilizes an augmentative and alternative communication device, an AAC device like a dedicated iPad with specific speech-generating software, you absolutely must bring it.
And from a purely logistical standpoint, you must bring the dedicated charger, and you must invest in an extra-long 10-foot charging cable.
Oh, the 10-foot table is a pro tip.
Because the electrical outlets in a hospital room are designed to power medical monitors directly behind the bed. They are never, ever conveniently located near where the child is actually sitting or resting with their device.
No, they aren't. But relying solely on an iPad in an emergency room is a risky game.
Tech fails.
Tech fails constantly. Screens shatter, devices freeze. Or, most commonly, the battery simply dies during hour 9 of a 12-hour wait in a chaotic A&E hallway.
Which is precisely why every digital voice must be backed up by an analog voice. You must bring low-tech physical communication backups.
Like what?
We are talking about laminated picture communication boards or a metal ring holding communication cards with their most basic vital needs. Things like pain, thirsty, bathroom, scared, too loud. The Boston Children's Hospital packet is phenomenal in this regard. They actually provide printable visual supports directly in their prep materials.
I was looking through those printables too, and they heavily feature a tool called a first-then board.
Yes, the first-then board. For those who haven't used one, it's a very simple, clean visual layout showing 2 blank squares side by side. The concept is that you place a picture of a required task in the first box and a picture of a preferred activity in the second box.
So first this, then that.
Exactly. So before the nurse approaches, you show the child the board. First, blood pressure cuff, then iPad. Why is such a simple visual tool so remarkably vital in a clinical setting?
To understand why the first-then board is vital, we have to take a deep dive into the neuropsychology of medical trauma. What actually constitutes trauma?
It isn't just the experience of physical pain.
No.
Yeah.
A child can scrape their knee playing on a playground, experience pain, and not be traumatized by it. Medical trauma fundamentally stems from a profound, terrifying loss of autonomy and a total lack of predictability.
Okay, let's explore that. Put us in the mindset of a nonverbal child in that hospital bed.
Imagine lying in a strange bed, feeling physically terrible. Suddenly, an adult stranger wearing a mask and a gown walks right into your room. They do not speak a language you understand. They grab your arm and they tightly strap a loud mechanical cuff to it that begins to squeeze your arm painfully tight.
That sounds awful.
Now, if you do not possess the cognitive or linguistic framework to understand why that's happening, to understand that this squeezing is measuring your blood pressure to keep you safe, it does not register as medical care. Your brain registers it as a random, unprovoked physical assault.
That is chilling. Without context, medical care is indistinguishable from an attack.
Exactly. It is completely random, terrifying, and inescapable. The first-then board, or a broader visual schedule of the day, is a tool specifically designed to combat that exact terror. It restores a baseline level of predictability to the child's universe.
It gives them a heads up.
It visually communicates a vital promise. This unpleasant, scary thing has a defined, immediate end, and the absolute moment it is over, it will be followed by something safe and comforting. You are giving them a map through the pain. It is a fundamental, empirically proven tool for reducing long-term medical trauma.
That is an incredibly powerful framing. You aren't just packing toys, you are packing trauma prevention tools.
That is exactly what they are.
Okay, we have covered an immense amount of ground regarding the child. We have built their informational passport, secured their physical stash, and designed their individualized sensory and communication toolkit.
And now we have to pivot.
We do. And honestly, this next section is often the hardest for a medical parent to actually listen to, internalize, and execute. We are talking about Section 4, the Parent Survival Kit, the oxygen mask rule.
It is intensely difficult for parents to engage with this because it directly contradicts their deepest biological instinct. When your child is in a severe medical crisis, the parental instinct is complete self-effacing sacrifice.
You just want to give them everything.
You want to pour every ounce of your energy, your attention, and your physical endurance into your child. Focusing on yourself for even a second feels like a betrayal of that instinct.
But that instinct, while beautiful, is entirely unsustainable over a 2-week hospital admission. There is a beautifully written, brutally honest blog post we reviewed from a mother in the Fountainheart community. She was writing this as her child was going through their 3rd major open-heart surgery.
A truly harrowing experience.
And she writes about finally understand the classic, cliché airplane safety rule. In the event of an emergency, you must secure your own oxygen mask before attempting to assist others. She wrote a sentence that every medical parent should memorize. An unconscious parent is no good to a child.
The physical toll of sustained caregiving in a pediatric ward is absolutely staggering. You are sleeping in bizarre positions, you are eating poorly, and you are existing in a constant state of hypervigilance. And parents almost entirely ignore this physical degradation until they completely crash.
They hit a wall.
They do. If we look at the Fondant Mother's blog, notice the highly specific, seemingly trivial items she lists as absolute non-negotiable essentials for her bag. She doesn't just list clothes, she lists heavy-duty hand cream, thick lip balm, high-quality moisturizing eye drops.
And she explains exactly why, which I found fascinating. She talks about the reality of infection control. Going in and out of the pediatric intensive care unit, you are mandated to use the hospital-grade high-alcohol hand sanitizer dozens of times a day.
It ruins your skin.
She washed her hands so frequently that her knuckles were literally cracking open and bleeding. She talks about the air in the hospital being so heavily filtered, dry, and sterile that her lips were constantly chapped, and the skin on her face felt painfully tight. Her eyes burned from exhaustion and dry air.
And here is where we must examine the insidious psychology of parent guilt, because guilt becomes the enemy of sustainable caregiving.
Tell me about that.
In that same blog post, she admits something deeply vulnerable. She was sitting by her baby's bed. Her hands were bleeding. Her lips were cracked. She desperately needed that hand cream. And she knew there was a fully stocked hospital pharmacy right on the ground floor of the building.
Oh, no.
It would have taken her a maximum of 5 minutes to take the elevator down, buy the cream, and come back. The ICU nurses were standing right there, fully monitoring the baby. She had the time, but she didn't go.
Why? Why sit there and suffer when the solution is 5 minutes away?
Because of the guilt. She writes that she felt it was deeply selfish to leave. Her internal monologue told her that if her infant daughter could endure the agony of open-heart surgery, complaining about dry skin and leaving the bedside to buy moisturizer was shameful, absurd behavior.
The logic of trauma tells you that your suffering must match your child's suffering.
Exactly. But as she eloquently reflects years later, attending to your own exhausted, breaking body is not selfish. It is the absolute foundational requirement for ensuring you have the physical stamina and mental clarity to advocate for your child over the long haul.
You have to survive to protect them.
By anticipating this guilt and pre-packing these exact items, the heavy hand cream, the lip balm, the eye drops, you completely bypass that agonizing psychological decision later. You do not have to choose between your basic physical comfort and your perceived duty to stay bolted to the chair. The comfort is already right there in your bag.
That reframing is essential. Packing self-care items is not a luxury. It is an act of caring for your child because it keeps their primary advocate functional. Which brings us to the next phase of parental survival, creating what I like to call the microhabitat.
The microhabitat, I love that phrase.
Because let's be entirely honest, a hospital room is sterile, it's cold, and the furniture provided for the parents is usually medieval.
Medieval is a highly generous description of the pull-out vinyl sleeper chairs found in most pediatric wards. They are designed for extreme durability and easy disinfection. They are not designed for human spine support.
Right. So how do you transform a sterile vinyl slab into a livable microhabitat where you might actually have to sleep for 3 weeks? The hand-to-hold packing list provides phenomenal specific suggestions. First, bring an egg crate foam mattress topper.
That makes such a difference.
It rolls up tightly, but rolling it out over that vinyl chair changes everything. Bring a real high-quality pillow from your own bed at home. Bring a proper heavy blanket because, as the checklist accurately notes, hospital blankets are notoriously thin, scratchy, and linty.
They're the worst blanket.
They really are. And you must pack clothing that allows you to dress in layers because the central climate control in a hospital is completely detached from reality. Your room will either mimic a meat locker or a tropical sauna, and it will switch between the two without warning.
And regarding exactly what type of clothing you should pack, there is a brilliant piece of strategic advice from Emily Marino, a parent support navigator who is heavily quoted in Audrey Vernick's Ultimate Survival Guide. We refer to it as the Sweatpants Strategy.
Okay, I love the Sweatpants Strategy. Tell us about it. Emily says, consider sleeping in sweats, as pajamas can lead to embarrassing interactions with medical personnel in and out of the room at all hours.
It is an intensely practical strategy rooted in the reality of the hospital clock. In a hospital, there is no such thing as true nighttime. The operational machinery never stops.
People are always coming in.
Yes. A nurse will enter the room at 2 a.m. to check vitals, empty a catheter, or hang a new bag of fluids. The surgical resident might come in at 4:30 a.m. to do a quick physical exam before their morning shift begins. If you are sleeping in traditional, flimsy pajamas or a sleep shirt, you are suddenly at a severe professional disadvantage.
You wake up, you are startled, and you are immediately scrambling to pull up the blankets and cover yourself while simultaneously trying to understand complex medical information.
Yes. You completely lose your footing as the resident expert. If, however, you adopt the sweatpants strategy and sleep in thick, presentable loungewear, nice sweatpants and a decent sweatshirt, you are instantly ready.
You're dressed for business at 4 a.m.
When that doctor walks in at 4 a.m., you can stand up, look them in the eye, and have a serious, authoritative conversation about your child's renal function without feeling exposed or vulnerable. Furthermore, it allows you to sprint down the hallway to the family kitchen to grab a coffee, or run out to the hallway to speak privately with an attending physician without needing to ask them to wait while you change your clothes. It maintains your dignity and your constant readiness.
Dignity and readiness. I love that combination. And speaking of readiness, there are some incredible environmental hacks for managing the physical space of the room itself.
Yeah.
The guide suggests bringing a small plastic bin or a shower caddy specifically for your own toiletries.
A shower caddy is brilliant. Why do they suggest that?
Because you will almost certainly be transferred at some point. Your child might move from the pediatric intensive care unit down to a step downward or to a completely different floor. When transport arrives, you want to be able to grab your toothbrush, your face wash, and your deodorant in one single motion, rather than frantically gathering individual bottles from around the hospital bathroom sink.
That is so smart.
Okay.
Another crucial environmental hack addresses a very real, very visceral, but rarely discussed reality of hospital life: odor management.
Oh, yeah. Let's talk about the smells.
You need to pack a strong room spray, a can of Lysol, or a small plug-in essential oil diffuser. In pediatric care, particularly when caring for children with complex medical needs, severe feeding issues, or surgical wounds, bodily output is a clinical metric.
Right. The hand-to-hold guide is incredibly blunt about this reality. It explicitly states all output needs to get weighed or measured, and it can stink.
Exactly. Diapers, ostomy bag contents, vomitus. The nurses cannot simply throw these away immediately in the bin outside. They often have to be saved in the room, sometimes for hours, so the clinical team can precisely weigh and measure the volume of output to calculate fluid balance and kidney function.
So you are basically trapped in a small, warm room with bodily fluids.
You are. Masking that smell is not a luxury. It is crucial for your own sanity, and absolutely necessary if you hope to be able to eat a meal in that same room without extreme nausea.
Wow. The harsh realities of the ward. Other vital environmental additions. Pack an extra long indoor extension cord. The electrical outlets in a hospital room are strictly clustered around the headboard of the patient bed to power vital medical equipment. There's rarely an available outlet near the parent's pull-out sleeper chair across the room, which is exactly where you need your phone to charge so you can hear the alarm you set for the 3:00 a.m. medication dose.
And the tape. Don't forget the tape.
Yes. Finally, bring a roll of gentle medical tape and some thick paper or cardboard. You will use this to block out the harsh fluorescent hallway light that inevitably shines directly through the little glass window in the door all night long.
That window light will drive you insane.
It really will. Okay, we mentioned trying to eat a meal in the room earlier. We have to talk about nutrition on the ward. First and foremost, the guides insist you bring your own large, durable water bottle and your own favorite coffee mug, or even a tiny travel Keurig if the hospital administration allows it.
Because the hospital coffee situation is usually dire.
It is. Trying to hydrate by constantly asking the nurse for those tiny, flimsy, ribbed paper cups or drinking terrible instant coffee out of styrofoam for 2 weeks is just profoundly depressing.
It sounds like a minor detail, but it is really about the psychology of endurance. It is the little, tangible rituals that keep you anchored to your identity outside the hospital. Holding your own ceramic mug, feeling its weight, smelling your preferred brand of coffee from home, it provides a microscopic but vital dose of normalcy in an entirely abnormal environment.
Now, regarding the actual food, we reviewed a fantastic source from a clinical specialist known as the cancer dietitian, which focused on convenient, non-refrigerated snack options for hospital stays.
The ambient snacks.
Yes, the focus is entirely on ambient snacks, foods that travel well, don't require a fridge, and can sit safely in a go bag for weeks. They suggest packing high-protein oat cakes, single-serve sachets of nut butter, shelf-stable milk cartons, Gent's trail mix, roasted chickpeas, and even tinned oily fish, provided you are brave enough to risk the smell in a shared double-occupancy room.
I would strongly advise sticking to the trail mix and leaving the tinned fish at home if you wish to maintain peaceful relations with your hospital roommate.
A very fair point. But looking at this extensive list of ambient snacks, I have to ask the obvious question here. Wait, hold on. Why on earth would I dedicate a quarter of my limited go-bag space to a suitcase full of oat cakes, peanut butter, and shelf-stable milk?
It seems like a waste of space, right?
Right. Every major hospital has a massive cafeteria. Many have a Starbucks, a Subway, or a Whole Food Court right downstairs in the lobby. Why not just take the elevator down and buy a hot, fresh sandwich?
It is the most logical question a parent can ask, but it collides violently with a harsh systemic reality of the hospital schedule. And that is the phenomenon of medical rounds.
Ah, rounds.
Yes. The medical team managing your child, the attending physician, the senior residents, the specialized fellows, they operate on a system called rounding. They move from room to room, examining patients and making the critical clinical decisions for the next 24 hours. And here is the brutal truth. They almost never, ever arrive at the exact time they say they will.
Okay, I see. They tell you, we will round on your child at 9 a.m. and then you just sit there waiting.
Exactly. They say 9:00 a.m., but an emergency happens on another floor, surgery runs long, and suddenly they don't walk into your room until 11:45 a.m. If you decide at 11:15 a.m. that you are starving, and you leave the room for 20 short minutes to go down to the cafeteria to buy that hot sandwich, you are almost statistically guaranteed to miss the exact brief window when the neurologist finally walks through the door.
And if you miss them, they move on to the next patient.
And you might not see them again until the next day. You miss your chance to ask questions, to push back on a dosage, or to report a subtle symptom you noticed overnight. By having a massive stash of high-protein ambient snacks readily available in your go-bag, you remove the necessity of leaving the room.
You can stay anchored.
You remain anchored to the bedside. But more importantly, you maintain your physiological capacity to advocate.
What do you mean by physiological capacity? Like literally having the energy?
I mean your blood sugar and your cognitive function. When that attending doctor finally walks in, they are going to deliver complex medical information rapidly. They're going to ask you to consent to a procedure or choose between 2 different anti-epileptic drug protocols.
You have to be ready to process that.
You need to be sharp. You need your executive functioning to be operating at maximum capacity so you can process that data and make critical, life-altering decisions at a moment's notice. You simply cannot do that if your blood sugar has crashed into the basement because you haven't eaten a single thing since dinner the night before. You will be foggy, irritable, and compliant.
Wow. So eating a handful of trail mix isn't just a snack break. Even the snacks are a strategic advocacy tool. You are fueling the resident expert's brain.
Exactly.
That is brilliant. Okay, that brings us to the final major pillar of our deep dive, Section 5, protecting your mental health and managing this system. Because the strange reality of a hospital admission is that while you are entirely trapped inside this sterile, timeless bubble, the outside world keeps turning.
Life, unfortunately, goes on without you.
It does. And managing the intersection between the hospital bubble and the outside world is utterly exhausting.
It is a phenomenal drain on a parent's limited bandwidth. When a medically complex child is admitted, especially with a life-threatening acute issue, your extended family, your friends, and your community naturally want updates. They love your child and they're desperately worried.
Which is wonderful.
But managing that well-intentioned information flow can rapidly become a second, unpaid, full-time job for a parent who is already stretched to the absolute breaking point.
Audrey Vernick's Ultimate Survival Guide has a very strict, non-negotiable rule for handling this. Appoint a spokesperson. Pick one highly trusted person, a capable friend, a sibling, a grandparent who isn't easily panicked, and designate them as the central communications hub.
This is a lifesaver.
You text the updates to that one single person, and it becomes their explicit job to disseminate that information to the 12 anxious aunts and uncles, to update the Facebook support group, and to coordinate the neighborhood meal train.
Because we really have to look at the psychological toll of not having a spokesperson. Think about the emotional labor of repeatedly typing out deeply traumatizing medical updates on your phone.
Oh, that sounds awful.
Every single time you type out the text message explaining that your child had another massive seizure or that their oxygen saturations dropped dangerously low again, you are forcing your brain to actively relive the trauma of that moment. Doing that 12 times a day for different relatives is emotionally destructive.
It's re-traumatizing yourself over and over.
It is. The guide heavily advises setting a firm, unapologetic boundary right from the moment of admission. Send one mass text that says, "We are entirely focused on our child's care right now. Name of spokesperson will provide updates when possible, or we will update you when we have the capacity." That single boundary preserves your rapidly depleting mental energy for where it is needed most. The bedside.
And to help preserve and replenish that mental energy while sitting at the bedside, the Font and Heart Mothers suggest bringing something called a token of hope.
A token of hope. Tell me more about that.
This is a tangible, physical item. It could be a beautifully framed photograph of your child smiling radiantly on a really good, healthy day at the park. It could be a specific religious symbol, a lucky charm, or a special piece of art they created. You place it right on the windowsill or the bedside table.
So it's always in view.
Right. When the sheer despair of the clinical situation gets unbearably heavy, when all you can see are tubes, wires, and dropping numbers on a screen, having a visual anchor provides a momentary escape. It gives your mind a place to rest and keeps you grounded in the reality of who your child is outside of this sterile room.
It is a vital reminder of who you are fighting for beyond the alarms and the monitors. And speaking of the fight, let's talk about the people who are actually in the trenches fighting alongside you. The hospital staff.
The staff are everything.
If you read every single survival guide across every different pediatric disease community, one advocacy tip is unanimously agreed upon. Make friends with the nurses.
Yes. Learn their names immediately. Look them in the eye when they speak to you. Say thank you. Treat them like human beings, not just cogs in the machine. But from a strategic standpoint, why is this specific relationship so incredibly crucial?
Because of the systemic reality of how a hospital functions. Doctors write the orders, but the nurses execute them, and the nurses are the ultimate gatekeepers of the ward.
They run the floor.
They absolutely do. A doctor might spend 10 minutes in your room a day. The nurse is there for 12 hours. They control access to the finite resources of comfort, the extra warm blankets, the better pillows, the ginger ale. If your child is in pain because a medication is delayed, a nurse who views you as a collaborative partner will make that third, aggressive phone call to the pharmacy to expedite the run.
They will fight for you.
But clinically, it goes much deeper. Nurses are the ones who notice the subtle, qualitative changes in your child's condition long before the quantitative monitors even trigger an alarm. They notice the slight change in skin tone, the shift in breathing patterns. Building a respectful, collaborative relationship with your nursing team is arguably your single most powerful advocacy tool.
Okay, before we conclude, we must touch on the systemic safety nets, because the administrative and financial burden of a hospital stay can quietly destroy a family while they are distracted by the medical crisis.
It's the hidden cost of illness.
Let's look at the administrative protocols, specifically highlighting the EHCP, the Education, Health and Care Plan for our listeners in England, and the Carers Allowance Guidelines from the UK Department for Work and Pensions, the DWP.
This is critical because it is vital to remember that a hospital stay does not happen in a vacuum. It reverberates outward, impacting a child's education and a family's fragile financial stability.
It affects everything.
If a hospital stay is planned, like a scheduled orthopedic surgery, or even if it evolves into an extended emergency admission, you must proactively check your child's EHCP. As the guidance from the Bournville School outlines, many parents mistakenly believe an EHCP is strictly for the physical classroom.
Right, but it's not.
It is not. A robust plan can and should include specific provisions for short-term educational or therapeutic support during school holidays, or, crucially, mandated support regimens after a child undergoes an operation. You want to ensure the local educational authority is legally fulfilling those obligations to support your child's eventual transition back to their daily life.
And then there is the terrifyingly complex financial side, specifically regarding the carer's allowance. The DWP guidelines outline very strict eligibility requirements. You have to be caring for someone for at least 35 hours a week, and you have to navigate a strict earnings limit of 196 parts or less a week after tax.
But buried in the fine print.
Yes, buried in the fine print, there's a very specific, highly dangerous bureaucratic trap regarding long-term hospital stays.
Yes, this is a vital administrative detail that catches many exhausted parents off guard. The Mobilized Guide to Navigating Carer's Allowance explicitly points out the 12-week rule.
The 12-week rule, how does that work?
The mechanism works like this. If you, the carer or the child you care for, are admitted to a hospital and the stay is expected to or does last longer than 12 weeks, the state bureaucracy assumes that the hospital is now providing the primary care.
Oh, wow.
Therefore, you must formally notify the DWP of the admission. Depending on the exact circumstances, your eligibility for the allowance may be paused or altered during that extended stay.
Even though any medical parent knows that when your child is in the hospital, you're actually working harder and caring for them more intensely than you do at home.
It is a fundamentally flawed bureaucratic assumption, but it is the law. And the danger is that if you fail to notify them because you are entirely consumed by the medical trauma of a 3-month ICU stay, the DWP will eventually find out.
And the absolute last thing a family needs when they finally bring their medically fragile child home after 3 grueling months is to walk to the mailbox and find a cold, demanding letter from the government demanding the immediate repayment of thousands of pounds in benefits because they missed a notification deadline.
It's devastating.
Do not let an administrative crisis compound your medical crisis. Delegate that miserable phone call to your appointed spokesperson if you have to, but get it done.
Exactly. The bureaucratic system is rigid, uncaring, and automated. You have to understand its rules to protect yourself within it so you can preserve your resources to keep protecting your child.
All right. We have covered a truly immense amount of ground today. We have systematically built the informational go bag, anchoring it with the medical passport and the vital system overriding baselines.
We have packed the physical go bag, anticipating the bureaucratic delays with our 24-hour stash, and ensuring access with adaptive snap front pajamas.
We have designed a highly individualized sensory and communication toolkit, recognizing that chew tubes and first-end boards are essential trauma prevention tools.
And we have secured the parent survival kit, the oxygen mask complete with heavy hand cream, the 2.0 AM Sweatpants Strategy, cognitive-saving ambient snacks, and firm boundaries for the outside world.
And if you look closely at every single one of those items, from the laminated picture communication board down to the bottle of baby oil for the EEG glue, they all serve the exact same fundamental purpose. They are tools for survival, they are tools for comfort, and most importantly, they are tools for active advocacy.
Packing this bag is not a chore. It is an act of fierce, uncompromising love.
So what does this all mean for you, the parent listening to this right now? It means you have the playbook. You know the logistics. You know how to prepare the physical and informational armor. But as we bring this deep dive to a close, we want to set the logistics aside for a moment and address the raw, emotional reality of actually walking through those sliding hospital doors.
Yes, because there is a profound, deeply moving thought drawn from Audrey Vernick's guide and echoing the sentiments of parent support navigator Ken Lininger regarding the unseen emotional cycle of a hospital stay.
The emotional cycle.
When you are the parent of a medically complex child, especially dealing with the condition as encompassing and unpredictable as PURA syndrome, You spend an inordinate amount of your life inside hospitals. And because of that frequency, there is often this heavy internal expectation, and sometimes an external expectation from friends and family, that you should be used to this by now.
Right, like it should be routine.
The assumption is that because you know the drill, because you have the perfect go bag packed, it shouldn't hurt as much.
But the source material beautifully and tragically dismantles that myth. It notes that grief is not a straight line. Grief is a cycle. A new hospital stay, even if it is your 10th, your 20th, or your 50th admission, will inevitably trigger a brand new cycle of acute grief.
The sensory triggers, that sharp smell of the hand sanitizer, the precise pitch of the monitor alarm, they bypass your logical brain and bring all the past trauma rushing back to the surface.
If you find yourself hiding in the tiny, fluorescent-lit hospital bathroom at 2 a.m., crying into one of those thin, scratchy hospital towels, despite having navigated this exact situation a dozen times before, it does not mean you have lost your strength.
It does not mean you failed to prepare adequately.
It does not mean you are a bad advocate. It simply means you are human. You are actively grieving the unfair reality that your child has to endure this suffering yet again. Allow yourself that grace. The immense preparation we discussed today, the medical passports, the first then boards, the sweatpants, none of it is designed to magically eliminate that profound grief.
It is designed to give you the structural support necessary to survive it.
Allow yourself that grace. That is the absolute perfect place to leave it. And, there's one final thought I want to leave you with, something that builds on all this advocacy we've talked about.
What's that?
Every time you use that medical passport, every time you respectfully demand sensory accommodations, every time you educate an ER doctor about the resting tone in PURA syndrome, you aren't just saving your child in that moment. You are changing the culture of that hospital.
Oh, absolutely.
You are leaving a legacy of knowledge. You are making it just a little bit safer, a little bit more compassionate for the next rare disease family that walks through those sliding doors at 3 in the morning. Your preparation becomes their protection.
That is a beautiful way to look at it.
Thank you so much for joining us for this special edition of The Deep Dive. Go pack your bags, update your medical passports with the latest baselines, French braid the hair, and take a deep, deep breath, because the next time you have to walk through those automatic doors and that sharp, sterile smell hit the back of your throat and the monitors start to beep, you won't just be a terrified bystander waiting for someone else to take control.
You will be the resident expert.
And you will be ready.